All right, welcome to this explainer. Today we're going to completely demystify the dense, high-yield CNS tumor data that you absolutely need to master for your radiation oncology boards and, your day-to-day clinical decision-making. Whether you're a resident right in the thick of your training or just looking to really solidify your evidence-based foundation, we've curated the absolute essential trials and targets to get you there. Let's get to it.
So here's our game plan for today. We'll start with ependymoma staging and treatment, move on to the landmark trials for low-grade gliomas, break down the standard of care for glioblastoma, and finally, tackle how to manage our elderly and frail patients.
Okay, Section 1, Ependymoma, Staging and Treatment.
What's really fascinating about ependymomas is how the microscopic pathology, those classic rosettes, literally dictates our macroscopic staging. Because of how these specific cells behave, we strictly require full neural axis imaging. That means checking both the brain and spine with MRIs, plus getting CSF cytology before we even think about designing our radiation fields. If the disease is localized, we're targeting the pre-op volume with a 1 to 2 centimeter margin, pushing the dose to 54.4 to 59.4 gray. But, and this is absolutely crucial, if you spot positive cytology or radiographic drop mets, you've got to shift gears immediately to craniospinal irradiation.
And when it comes to surgery, the math is just undeniable. Maximal safe resection is paramount. Subtotal resection, that's a massive red flag for outcomes. The numbers really speak for themselves. Subtotal resection has extremely poor outcomes, plummeting to a 43% 10-year overall survival. And that's even with adjuvant radiation. Now compare that to a whopping 83% survival rate when you achieve a gross total resection followed by radiation. It's night and day.
All right, moving right along to Section 2, Low-Grade Glioma Landmark Trials.
I always joke that pathologists must be constantly hungry because we always look for the classic chicken wire and fried egg appearance of an oligodendroglioma. But seriously, it's so important to ground our clinical data in the actual cells we're trying to eradicate. When you know the specific pattern is under the microscope, you instantly know you're dealing with a distinct clinical entity, one that's going to respond uniquely to our therapies.
Which brings us to a massive, really hotly debated historical question in our field. If these grade 2 tumors are notoriously slow growing, well, should we hit them hard and early with high doses of radiation? Or should we hold off and spare the patient from potential toxicity for as long as possible? It's a tough call, right?
So the whole debate really boils down to the classic believers versus non-believers trials. The believers trial basically asked, hey, are higher doses better? They compared 45 gray to 59.4 gray. And the answer? Absolutely no survival benefit to dose escalation. Then the non-believers trial asked if we should radiate early or delay treatment until progression. The results there definitively proved that rushing to radiate early does improve progression-free survival, buying patients about 2 extra years without tumor growth. But, and this is the kicker, it does not change overall survival.
So if we aren't just rushing to radiate everyone on day 1, who actually does need aggressive treatment? While this is a high-yield clinical pearl you absolutely must memorize for the boards. The RTOG 98-02 trial defined high-risk low-grade glioma as anyone under 40 with a subtotal resection, or literally anyone 40 and older regardless of their surgery. If your patient meets either of these criteria, observation is officially off the table. Why? Because they face a greater than 50% risk of progression at 5 years.
And when we do treat those high-risk patients, the results are honestly staggering. RTOG 9802 showed that adding 6 cycles of PCV chemotherapy to 54 gray of radiation nearly doubled the median overall survival. We are talking about a massive, game-changing leap from 7.8 years to 13.3 years. That finding permanently shifted the standard of care, easily earning a solid NCCN Category 1 recommendation.
But let's be real, while PCV is highly effective, it can be incredibly tough on our patients. Thankfully, the RTOG 424 Phase 2 trial gives us a super important modern alternative. It showed that the much better tolerated oral drug temozolomide, when given concurrently and adjuvantly with 54 gray, also robustly outperforms historical radiation alone controls. It achieved a fantastic 3-year overall survival of over 73%, a great option to have in your back pocket.
Okay, Section 3, Glioblastoma Standard of Care.
Diving into the Senai and LaCroix data, there is a strict, completely undeniable dose-response relationship between surgery and survival in GBM. The data shows that survival benefits really start to kick in at about a 78% resection. But if you can push that resection all the way to 100%, you push median survival from 12.5 months up to an impressive 16 months. Literally every bit of tumor removed counts.
Now, the absolute bedrock of modern neuro-oncology standard of care is the landmark 2005 STUP trial. This trial established our foundational chemoradiation regimen of 60 Gray in 30 fractions with both concurrent and adjuvant temozolomide for newly diagnosed GBM. It provided a highly significant survival benefit over using radiation alone.
Listen, if you remember only one single number from this entire explainer for your board exams or for when you're getting pimped by attendings on rounds, make it 14.6 months. That is the median overall survival for glioblastoma treated with the standard STUP regimen. It's essentially your baseline metric for everything else we do in this entire disease space.
So how do we push past that 14.6-month baseline? Well, we turn to an incredible engineering solution: tumor-treating fields. By adding these wearable scalp arrays, which patients wear for over 18 hours a day, to adjuvant temozolomide, we remarkably push that overall survival boundary past the 20-month mark, landing right at 20.9 months. It is just a fascinating engineering solution to a deeply biological problem. But of course, as we know all too well, GBM inevitably recurs. And when it does, RTOG 1205 teaches us exactly how to handle it. This trial showed that adding 35 grays of re-radiation in 10 fractions to bevacizumab is a phenomenal tool for local disease control. It dramatically improves 6-month progression-free survival from 29% up to 54%. That allows us to successfully manage neurologic symptoms, making it a major palliative victory, even if it doesn't ultimately extend overall survival.
All right, let's wrap things up with Section 4, Managing Elderly and Frail Patients.
The core idea that age alone shouldn't preclude radiotherapy is a clinical pearl you really need to carry with you. It stems directly from the landmark 2007 French trial by Jaime Guibert. See, for a long time there was a lot of nihilism regarding older patients, but this trial proved that for fit patients over 70, radiation therapy drastically improves survival compared to best supportive care alone. The takeaway? We don't just give up on patients because of a number on their chart.
So, the Roe trial asked exactly how we should radiate these older patients. And it brilliantly showed that cutting the grueling 6-week radiation schedule in half, delivering 40 Gray in 15 fractions over just 3 weeks, provides the exact same median overall survival for patients over 60. Plus, it comes with significantly fewer steroid requirements. So it's less time in the machine, the exact same survival, and a much better quality of life. A huge win.
Building perfectly on that ROA data, the Perry trial in 2017 demonstrated that if an elderly patient is fit enough, we shouldn't just stop at radiation. Adding temozolomide to that 3-week hypofractionated course significantly boosts overall survival from 7.6 to 9.3 months. And, crucially, if their tumor happens to be MGMT methylated, that survival leaps to an incredibly impressive 13.5 months.
But you might be wondering, what about our most vulnerable, frail patients who can't even tolerate 3 weeks? Well, we can shrink the treatment even further. Follow-up data from Roa and Guedes de Castro showed that an ultra-short course, delivering 25 Gray in just 5 fractions over a single week, is entirely non-inferior in overall survival compared to the 3-week course. This is literally a game-changer for preserving whatever precious time these frail patients have left.
So, to put it all together, we can build a high-yield algorithmic cheat sheet for the clinic. You strictly map the radiation dose and the decision to use systemic therapy against 2 key things: the patient's performance status and their MGMT methylation status. It completely takes the guesswork out of tailoring treatment for our elderly population.
As you head back to the clinic and onto the wards, I want you to really consider this. With molecular pathology redefining these tumors faster than our clinical trials can even keep up, how will you adapt these foundational radiation algorithms for the patients of tomorrow? The trials we discussed today built the standard of care, but you are the ones who will write the next chapter. Keep studying, keep asking the hard questions, and we'll catch you in the next explainer.